Good afternoon and welcome. My name is Dr. Carlos Perez. We're at Nova Southeastern University, and today is World Suicide Prevention Day. Please correct me on that one. And we've got students who are going to be assisting, and Dr. Poland, our key speaker. Just to start everything off, we're going to poll our audience for a few matters. So the first poll is, I'm attending the webinar today as a student, a mental health professional, a community member, a medical professional, an educator, other. And we've got 68%, 70% of the attendees have voted. Can you all see that?
Yes.
Very good. And we're at 83%. We'll give it a few more seconds. And Mindy, you'll see the poll in 1 second. We're going to launch it. You should be able to see your poll. And I'm going to go ahead and launch, end that poll. And why don't you go ahead and read the results?
So we have 25%, which are students, 52% who are mental health professionals, about 3% that are made up of the medical professionals and community members, 17% who are educators, and then there's about 10% of you others.
Okay, and let's go to the next poll.
We have some people here that can't see the poll. I don't know if you have any suggestions for them.
It could be their browser, I'm afraid, but most people could see it. We could. That's why we're reading them to them. So the next poll is NSU webinar attendance. Is this your first time? Have you attended 2 or 3? Have you attended many previous webinars? So 72%. And we're at 700 attendees right now. Welcome, everyone. And I'm going to close the poll in just a few seconds. And then I'm going to close in 10 seconds. And the poll is closed. And you go ahead and read the results.
All right, looking at our webinar attendance for today, 38%, this is their first time attending an NSU webinar, so welcome. About 40% have attended 2 or 3 previously offered, and 23 have attended many previous webinars. So thank you guys for joining us again today.
Great, and I just have one more. I am comfortable speaking to someone directly about suicidal thoughts and or actions.
And while y'all are answering that, just to answer some of your questions, we cannot see your video or hear anything, so that is not an issue or anything for you to worry about during this.
Yeah, thank you very much. Because these are large audiences, we'll probably hit 1,000. We do not have you that you could share your camera. So 80% have voted. We could get a couple more. Are you comfortable speaking directly to someone? 3, 2, 1, and at almost 90%, I'm going to end polling and share results. You want to discuss the poll results?
So 68% of you said that you are comfortable speaking to someone directly about suicidal thoughts and or actions. 4% said no, and 28% said somewhat.
Very good. And that gives us a little introduction to who's here. Again, if you've just signed in, my name is Dr. Carlos Perez. You're at Nova Southeastern University. We are with the College of Psychology. And this afternoon, we have a number of graduate psychology students that are going to welcome you and then introduce our key speaker, Dr. Scott Poland. So who's going to start?
I'll start us off. Hi, everyone. My name is Melissa. I am the current president of Inspire, which is the suicide prevention and intervention organization here at Nova Southeastern University. Today, we are pleased to have Dr. Scott Poland, who is the director of the Suicide and Violence Prevention Office here at NSU. He is also a survivor of his father's suicide. He has authored or co-authored numerous books and chapters on this subject. Today, he will provide an overview of the incident of suicide. There are some predictions even that the suicide rate, which is already at a 50-year high, will dramatically increase due to COVID-19 pandemic. The warning suicides will also be outlined and the importance of obtaining professional help for suicide individuals. The importance of safety planning with suicidal clients will be emphasized, and tips for suicide assessment virtually will be provided. The results of several legal cases where Dr. Poland has served as an expert witness will also be shared. This presentation will dispel the common myths about suicide and stress how suicide is preventable. If at any point you feel that you are in a state of crisis or are aware of someone else that is in a state of crisis, local and national crisis resources will be provided. Over to you, Dr. Poland.
Thank you very much, Melissa. And indeed, I want to thank everybody for tuning in today. I hope to say some things that'll be helpful and meaningful to every single one of you. First of all, if anyone is in crisis today, very important that everybody knows the National Crisis Helpline number, 1-800-273-TALK or 1-800-SUICIDE. I know this has been a very difficult 5 months and it's still not over. And the virus has changed countless things in our country and around the world. What I hope is that you and your loved ones are safe. But it's been very difficult for all of us to deal with the uncertainty, financial losses. Some of you may have even lost a loved one to the virus. And I believe strongly this is a time, maybe more than ever before, when everybody needs to know what to look for and what to do to prevent suicide. And we have a lot of mental health professionals today, not so many community members, but not even every mental health professional said they were comfortable with direct inquiry about suicide. I also must acknowledge that without a doubt, some of you listening today lost a loved one to suicide. I was 25. I was a graduate student when I lost my father to suicide. And frankly, I would give anything to have that last conversation back. I should have asked directly, how did I not realize what he was trying to tell me? And I'm a good example of someone who never thought it would happen in my family. And if I could say one overarching thing today, it's really pretty simple. We must talk about suicide more. I know we have people from around the world today. Many of my comments will be focused on the United States, but it's certainly a worldwide problem with approximately 1 million suicide deaths in America. Across the world, 1 million. And the United States, it actually is about 48,000. So the last year we had these figures, 2018. Suicide rate was the highest in 50 years. You can all read these statistics. And years ago, I went to a presentation where the presenter spent 95% of the time showing me statistics about suicide. I finally raised my hand and I said, I knew it was a problem. That's why I walked in here. I want to know what to do about it. And I hope I give everybody information today about what to look for and what to do. We know males do die by suicide more often than females. We need to be especially concerned in the United States about the increase in suicide for middle school aged young people. about the suicide rate that has increased for Black children. And suicide is the second leading cause of death for everybody between the ages of 10 and 34. It's a problem for our veterans. It's a problem for middle-aged white men, and it has always been a problem for the elderly. An elderly person with family health and financial problems is at risk for suicide. Guns account for about 50% of the suicides in the United States. Here are the questions, and I think everybody tuned in today because you are concerned that suicide rates will continue to rise because of COVID-19. There's a lot of isolation. People have not been able to see extended families. They've not been able to go to the places of worship the way they used to be able to. Reduced access to our community, our loved ones, our places of worship. And our Center for Disease Control really emphasizes connections. And perhaps one of the greatest things we can do around the world to prevent suicide is simply to increase people's connections, their sense of belonging in their school, in their family, in their community, and their places of worship. And several students have helped me gather information, trying to look at historically, what do we know? What have we experienced that might help us with regards to suicide rates? The Spanish flu around the world, and particularly here in the United States, was about 100 years ago. We know that suicides went up after the Spanish flu. We also know suicides increased after the SARS outbreak in Hong Kong. And there have been reports around the world, you've all seen them, whether it's emergency room physician in New York or a farmer in India. There have been a lot of stories about suicides related to COVID-19. And even if we don't address suicide directly for a moment, we know that the virus and all the things that have come with it have likely increased domestic violence, child abuse, alcohol consumption, access to firearms. That might surprise you, but firearm sales in the United States have gone up significantly since the outbreak of the virus. And those that already had pre-existing mental health conditions, well, we would expect those to be exacerbated. We also know that suicide rates have been tied to issues with regards to finances, the crash of the stock market, the increase in the unemployment rate. Those have historically increased suicide rates. So I want to emphasize again, this is a time when we all must be comfortable with direct inquiry, and everybody needs to know how to get help for themselves or their friends. And sometimes I take the time to demonstrate. If I were to pick up my iPhone and push the button and tell Siri I want to kill myself, she immediately responds, "May I connect you with the National Crisis Helpline?" Everyone needs to know that there are resources right on our smartphone. Now, there were some surveys recently. The National Action Alliance, and if you were to think of that simply in the United States, that's bringing all these important stakeholders and organizations that focus on suicide prevention, bring them together, and coming out with just a few days ago, a survey about Americans. And the majority said that because of the pandemic, suicide prevention should be a national priority. I can assure you it has never been a national priority, but it needs to be. Thankfully, 93% of those surveyed said suicides can be prevented. We need 100% to know suicide is preventable. And then a large percentage identified barriers that keep them from discussing suicide. Let me quote our previous Surgeon General. We need to talk about suicide more in our homes, our schools, and in our places of worship. And a simple idea I have, if we were actually teaching every middle school and high school student in this country how to help themselves, how to help their friends if somebody is suicidal, then future generations of Americans would know what to do. They would understand it's preventable. It's no one's fate. It's no one's destiny. The intervention of any one person can make all the difference in the world. So at the Suicide and Violence Prevention Office here, we've interviewed a lot of very notable people in the field. Dr. Lanny Berman, a giant in suicide prevention, the executive director of the American Association of Suicidology for decades. In the interview, which we'll find on our website, he stressed, unfortunately, we don't fund suicide prevention. The funding lags significantly behind that for the other leading causes of death in America. Then I also interviewed Dr. Iness, who wrote a book about guns and suicide. Please know, I'm not here today to question any adult's right to own a gun, but with that right to ownership comes a responsibility to safeguard that gun from a troubled, depressed, impulsive, mentally ill person that might reside in your very own home. Clinicians sometimes are hesitant to discuss gun availability with suicidal clients. They must get comfortable doing that. And actually, Florida is a state where we passed legislation trying to forbid mental health professionals and physicians from even asking in a confidential setting about gun ownership. Thankfully, the Florida Supreme Court overturned that legislation. But let's look at Dr. Iness's quote. Separating an individual from the method they are intending on using for suicide is the most powerful tool we have to keep suicidal people alive. I don't think there's even a close second, he went on to add. If you're a mental health professional, if you're a student studying psychology or counseling, please know you must discuss lethality and means with suicidal clients, students, and patients. Then Dr. Joyner, who's at Florida State. He's the Robert Lawton Professor of Psychology. Again, another giant in the field. So what did he say in the interview that I did with him? The most common mistakes clinicians make in suicide assessment are to mischaracterize the risk level. Or they make an accurate assessment of the risk level, but they don't take appropriate action to secure client safety. Or the clinician overestimates the effect of protective factors. Training is needed. And that leads me to the quote from Dr. David Jobs at the Catholic University of America. What he says may surprise you. There's a shocking lack of curriculum-based training on suicide risk assessment and management across all healthcare disciplines. Most clinicians, if and when they learn, it is in the field. The American Psychological Association, for example, does not require a competency in suicide risk assessment and management. I teach that in my crisis intervention class here, but it's an elective. It's not a required course. I mentioned Joyner just a moment ago. Here's his model, widely believed to be the most accepted model of suicide in the world. If Joyner were here today, he'd say, lots of people have a desire for suicide. They perceive themselves as a burden to their family. They have thwarted or low belongingness. but they have to acquire a capability. If anybody's ever said to you, suicide is cowardly, Joyner would disagree. He would say, a suicidal individual is fearless. They're overcoming the most basic instinct we have, which is simply to stay alive. And how do they acquire that capability? Through reckless behavior, maybe through self-injury, maybe through an extreme eating disorder. They're working up to it. And we need to be alert to people that are acquiring the capability of suicide. Last month, the Kaiser Foundation did a survey. And basically, not surprisingly, the majority of Americans say their lives have been disrupted by the virus. They're worried about financial security. They're worried about a reduced income. They worry about a family member getting sick. They worry about going back to work. They can't afford to miss work, but they don't want to get sick. So the stress that they're experiencing may be among the greatest in modern times. This is why we need increased mental health services throughout our country and throughout the world. And if I tuned in today, I would have a simple question. What works? This is from the World Health Organization. Reduce the lethal means. That means putting a barrier on the bridge. That means in Taiwan, where I presented, locking up the pesticides. In the United States, it means securing those guns, removing the lethal means. Education for everybody about the warning signs, especially for physicians. I'm going to speak very honestly today. At my age, I get to do that. Two groups that I've been frustrated with. Physicians, they need to seek out training on suicide prevention. The bottom line, about 70% of the time, the person who died by suicide went to see their family physician shortly before their death. I know my father saw his physician 2 weeks before he died. The second group, that would be school principals and superintendents. They need to step forward and partner with community, state, national resources for suicide prevention. And we need to, as I stated a moment ago, improve, increase the mental health services available to the people struggling all around the world in the aftermath as this virus continues. I'd be remiss today not to at least show you the common warning signs of suicide. And if everybody just knew these, we could prevent so many deaths. When somebody's talking and writing about death, dying, and suicide, that is something we must pay attention to. When they're making statements about feeling hopeless, feeling trapped, they're in a state of despair, they're giving away prized possessions. My dad talked about what he wanted to leave me. And how did I not realize what he was planning? Making out a will, dramatic changes in behavior, and the majority of those individuals who died by suicide exhibited one or more of these warning signs. Sometimes people tell me there was nothing. There was no warning sign. There was always at least something, but it might have been very subtle. But most of the time, they exhibit pretty definite warning signs. And Harvard has a website called Means Matter. They've surveyed the research all around the world. You remove the lethal means, lives are saved. It is that simple. And I've been so frustrated a few times in my career when I'm telling the parents of a student that their child is suicidal. They have a plan to use the family gun, and parents will not take steps to remove it. One Houston teenager wrote in her goodbye letter to her parents, Why did you make this so easy? Why did you leave this gun available to me? Protective factors. These also come from the World Health Organization. Although Joyner cautioned, don't overestimate the protective factors. Connections, we've talked about those. Coping and problem-solving skills. Access to mental health services. Knowing when and knowing how to seek help. Religious involvement. And lack of access to suicidal means. Around the world, those are the protective factors. And there are particular challenges. Many communities, many places around the world lack mental health services. And there's a lot of stigma about seeking mental health treatment. Last year in Montana, somebody said, I can't go to the mental health center. It's the only one for 50 miles. My second cousin is a receptionist. Everybody will know. Well, in congested areas like South Florida, unlikely that our second cousin is going to be the receptionist. But there is still, unfortunately, a lot of stigma about seeking mental health treatment. There have been a lot of initiatives to try to prevent the suicide of veterans, to try to prevent the suicide of our active duty service members, but often that stigma stops them from going to seek treatment. They feel like they will be viewed as weak if they seek treatment. A strong person realizes when they need help and they seek it out. And at the root of suicide is simply untreated or undertreated mental illness. And I'll state again, for all the students that are listening, you need to seek out suicide risk assessment and management. You need to get that training. If you're practicing already, seek out training, and I'll talk a little bit about some of those resources in a few moments. Those of you who know me realize that I've spent the bulk of my career working on suicide at the K-12 school level. And along with my partner, we did state plans for Texas schools, Montana schools. We've submitted a draft for the New Jersey schools. And I'm proud to tell you, with the doctoral student here at NSU, Catherine Ivory, we are just now completing the Florida steps, school toolkit for educators to prevent suicide. Schools can't do this alone, but they have a very definite role and must partner with state, local, and national resources. There's been a lot of concern, understandably, about telehealth, virtual learning. How can we do suicide assessment when that student, patient, or client is not sitting right there in that confidential setting, in that room with us? And frankly, no one has all the answers here. But I'm really proud to say that the National Association of School Psychologists has worked on this, and they've produced the Comprehensive School Suicide Prevention in a Time of Distance Learning Guide, and they have both a prevention and an intervention checklist. And I encourage everybody to take a look at those resources. And the simplest place to start is to begin with, let's review the school suicide prevention plan, and let's figure out how we are going to adapt that to virtual learning. And whether it's the client or the student, if we are online with them, we need to know exactly where they are. We need a backup plan should that internet connection fail. And in particular, if that is a school-age student, then we need to know, are their parents in the home? If they're not in the home, Do we know where parents are? We know how to contact those parents. So having that communication backup plan, should our connection go down, or should this be a minor, and it be essential that we get in touch with their parents? And is there a privacy situation where the student feels like they can talk confidentially to you without somebody else in their home overhearing that? So much preferable to be online so we can actually look at the person. We can watch their body language. We can get a much better reading on what's going on as opposed to only having a phone connection. So these are important things to keep in mind. And when somebody is suspected of suicidal behavior, we need a safety plan. Now, unfortunately, I still sometimes hear that professionals are using no suicide contracts. Please know those are outdated. Those have been sorely criticized. They will not protect you from liability. Why have they been so criticized? A no suicide contract is all about what not to do. A safety plan developed jointly is all about what are your ideas to keep yourself safe. When you've had a suicidal crisis before, what did you do? How did you get through it? Internally, what things have you done? What things can you do to calm yourself down? Externally, who can you turn to? These safety plans need to be written. They need to be reviewed frequently. And if the student or client has lost the safety plan, you have a copy. Let's get it out. What else can we add to it? And there are a couple of great apps that would allow the therapist to help the client upload their safety plan on either My3 or Not Okay. And I recently had a conference with Signs of Suicide. It's the SOS program. It's middle school through college, and that program is evidence-based. It has two primary components. It has very well done videos with the motto ACT, acknowledge, care, tell. Tell a trusted adult. Tell someone else. Get help. And when you ask someone about being suicidal, if they're having those thoughts, it actually gives them the chance to unburden themselves, to realize they are not alone. You're not the first person to feel this way. There is help available. I will be there for you every single step of the way. What is holding suicide prevention back, at least for community members and the layperson, they're afraid if we bring this up, it will cause somebody to think about suicide for the first time ever. The research says absolutely not. And if anything, if they've never thought about it, then I might respond by saying, well, if you ever have those thoughts, or if your friend ever has those thoughts, let's talk about what you could do to help them. And make sure they know about the National Crisis Helpline. Make sure they know about the National Crisis Text Line. Make sure they know about resources. And since I know we have a number of university students right here at NSU, Florida on today, we have the Student Counseling and Wellness Center. It's available to you. The sessions are free. It's like everybody needs to know their local state, and national resources. So back to the signs of suicide. I said it had very well done videos. I really like their videos because nobody dies. Somebody is suicidal, but somebody intervenes, gets them the help that they need, whether that's a friend, whether that's a teacher, whether that's a parent. But the second component that SOS has is a brief screening instrument. It only has 7 items, and questions 4 and 5 are the key ones about suicide. The rest are more about general depression and not feeling as good or as strong or as successful as you normally do. And SOS is working on procedures to be able to conduct their program virtually. That's what our advisory committee meeting was about. But I'm going to be honest and say something that even though it's evidence-based, I'm a great supporter of that program. It's very difficult to get schools to implement anything that has to do with universal screening about suicide. Yet the data just came out. I have it right here. 2019, the Youth Risk Behavior Survey of high school students said that 36.7% of them felt sad or hopeless for 2 or 3 or more weeks in a row during the last 12 months. And 8.9% of high school students admitted to a suicide attempt in the last 12 months. Does it make any sense to you that we don't talk to high school kids about how to help yourself, how to help your friend? In fact, what I hear more and more is 4th and 5th graders are talking about suicide. And I've actually responded to several suicides of kids as young as 9 years old. The question I always get is, do I have to take it seriously? Yes. I don't care how old he is. Take it seriously. Provide help. Make sure his parents or her parents are notified. So I hope you're all thinking about questions. I've been involved now in at least 15 K-12 legal cases that involved the tragic suicide of a student. I wish I could take the time to go over every single case with you. But what have I learned? The parents of a suicidal student must be notified. Only one exception. You believe the kid is being abused, now you're calling protective services. Do you notice I stated there, regardless of age? If a kid is still in high school, my advice to you, I don't care how old they are, tell their parents. That has been an issue in legal cases. And the school procedures to prevent suicide, we must know them and we must follow them. Peer reports that a friend is suicidal must be taken seriously. And so I actually train school counselors. So a kid's in a school counselor office for 10 minutes, 20 minutes, 30 minutes. Who do you think knows that kid the best? The school counselor who's seen them, maybe this is the first time ever, or their peer who knows they've been talking about suicide or maybe even planning it for weeks or months. And I'll quote Dr. Berman, very common for a suicidal individual to deny being suicidal. So if they're in my office, they were suspected of being suicidal, they deny it, I'm still going to call their parents and say, you know, when I asked directly, your child said no, but I have other information that made me think he or she was at risk. There's been a lot of lawsuits about bullying and suicide. So what's the research say? What's the Suicide Prevention Resource Center say? By the way, if you haven't heard of what's called SPRC, please check it out. And SPRC is our national resource for suicide prevention. They actually send out a weekly spark by email every Friday that provides the latest information. Where's the grant money? What's the research saying? So Suicide Prevention Resource Center is an excellent source of information for all of us. So they reviewed some 40-odd studies looking at the relationship between bullying and suicide. Strong association, yes. Causation, no. How are you going to rule out untreated or undertreated mental illness, losses, all kinds of adverse childhood experiences? Please know that both the bully and the victims of bullying are at risk. So what's the one thing I hope you'll remember? If you know a young person is involved in bullying, either as the bully or they're the victim, do not hesitate to ask them directly about hopelessness, giving up, and thoughts of suicide. I've tried to follow this carefully. I'm not aware of a single parent that has won a civil lawsuit charging that the school's failure to stop the bullying was the proximal cause of their child's suicide. I could give you specifics of schools who settled out of court, but to my knowledge, we do not have a legal precedent in court. And I'm going to quote my youngest daughter, the attorney. Dad, suing the school, that's like suing the government. The plaintiff is rarely, if ever, going to win. Well, that's pretty true. But there have been times when schools, K-12, and universities have made some pretty huge mistakes related to a suicidal student. And we should all learn from those mistakes. And I'm going to go over one very specific case with you. Now, you're wondering why I don't give you the case number? Why I don't tell you the name of the prestigious university? I can't. I signed one of those non-disclosure agreements. And if you're wondering, I was on the side of the plaintiff. So let's look at the specifics. He had a full scholarship. He was a freshman. He was far from home. And just before the December holidays, he walked into the student counseling center and he basically said, I'm having some suicidal thoughts. I had these last year in high school. I never acted on them. They basically said, well, you're going home for the holidays. I'm sure you'll cheer up. Well, he came back on January 13th. This time, he told the counseling center, I'm researching how to kill myself. They gave him an instrument called the CCAPS, commonly used in university counseling centers. He scored at the 99th percentile on depression. Well, they made an appointment for 2 days later. That was a good thing. On the 15th of January, he repeated that I'm researching how to kill myself. And then he added, my partner broke up with me yesterday, saying they were only using me to get their old partner back. Now, is this starting to sound pretty serious to you? Remember when I quoted Joyner and he talked about mischaracterization of risk or not taking sufficient actions to protect and secure safety for the client? Okay. Well, they made an appointment 1 week later. On January 22nd, he was going to get to see the psychiatrist. Unfortunately, the day before, he died by suicide. The counseling center psychologist stated in their deposition, they had no idea a safety plan should be written, they thought a verbal one would be sufficient. They also stated they had no concept that a romantic breakup might precipitate a suicide attempt. So what are the most common precipitants to a suicide attempt? Breakup of a romance, loss of a job, extreme humiliation, legal issues, like about to be arrested. Those are pretty much the top ones. What's that mean? They traveled a long road. Every individual who died by suicide traveled a very long road. But something happened. Something precipitated and caused them today to take action on these previously thought out suicidal plans. So I hope you're wondering about the legal outcome of this case. And I know student counseling center policies at the university level are pretty much, we never contact parents. And I asked our previous counseling center director here, I said, what would you have done? He said, I would have brought up the parents. I would have said, let's talk about your parents here. I think your parents could probably be of help. What do you think about we call them? And I met both parents of this suicide victim. They would have been on the next plane to see their son if they had only had that opportunity. I also know what they really want to do, because the university settled out of court, so I can't direct you to a legal precedent and give you a case number, but I know what they really wanted to do with that monetary settlement. They wanted to start the Make the Call Foundation to at least keep the option open to rule in parents of college students as opposed to automatically ruling them out. But because they also signed that do not disclose form, they can't start the Make the Call Foundation. There's no absolute answer here, but everything we know about college freshmen is that they are not as mature and as advanced with all of their intellectual abilities and their ability to control everything as they will be later in life. Something I'm really proud to tell you, and we only started it this week. First year freshmen at NSU, Florida, are receiving suicide prevention information. We have a model, a program in place for every university freshman on our campus, directed by the Suicide and Violence Prevention Office. Though I said the university settled out of court, what were my criticisms? They didn't take appropriate action. Seeing the psychiatrist 1 week later was not good enough. Maybe that student should have been immediately hospitalized or seen every day if that's what it took. And the safety plan should have been written. And we must all recognize precipitating events and at least bring up the idea. It would be helpful, I think, if we get your parents involved. A couple of final thoughts while you're thinking about your questions. It's a very critical time all around the world for everybody to know what to look for and what to do to prevent suicide. Mental health professionals, they have to seek out good training on suicide risk assessment and management. Suicide prevention funding needs to be increased all around the world. And if you were to look at the data around the world, you would find something like this. The Middle East has no suicides. I think we know they do. They just don't report them. You would find the United States ranks 12th with regards to the highest suicide rates in the world. You'd find that some countries like Guyana are right at the top with regards to the suicide rate. You'd be surprised to know that although China has a large number of suicides, the actual rate is not among the highest in the world. And suicide rates are always given per 100,000 people in a particular age group. That's how suicide rates are reported. And don't hesitate to simply say, are you thinking of giving up? Are you thinking of suicide? I only wish I'd have known enough to say those things to my father. And self-care plans, those are critically important right now. Everybody is under stress. We've got to be getting good nutrition, getting the proper amount of rest. We got to exercise. We got to stay in the moment. We can't worry about the things that haven't even happened yet. And we've got to seek out the positive people in our life and be that positive person for other people. Here is a great quote from Giovanni Martin. No one can do everything, but everyone can do something. And if everyone does something, together we can change the world. And that is so true with suicide prevention. Most suicide prevention is actually driven by survivors. We're not going to give up. There is the website for the Suicide and Violence Prevention Office here at NSU. We put out newsletters. We do training all around the campus and around the community. There's how to contact me if you're interested, and I do try to respond to every email I receive. And Dr. Perez told me that automatically you will receive an email with a copy of the PowerPoint for this presentation. And while we are about to turn to questions, check out the American Association of Suicidology. They actually have a very inexpensive student membership. They put on an annual conference. Check out the American Foundation for Suicide Prevention. There are chapters all around the country. They sponsor the Out of Darkness Walk, which NSU is typically hosted, but this year's Out of Darkness Walk will be virtual. And there is the Suicide Prevention Resource Center, which can guide you. All of these websites can guide you to training. And I meant to put in a slide about the Columbia Suicide Severity Rating Scale. It's free, can be used with any age. It's been translated into 100 languages. I like to joke with Kelly Posner of Columbia. She took the 3 questions I've been asking for decades. Have you ever attempted suicide? Are you thinking about suicide now? How would you end your life? She took those 3 questions and made it into 6. But the Columbia Suicide Severity Rating Scale is very well known around the country, especially in emergency rooms. And if you check out the Columbia Lighthouse Project website, there are training videos on the Columbia. And I'm going to turn it back to you, and I want to thank Melissa, Taylor, and Brittany for Inspire's interest in suicide prevention. And let's see if we have some questions.
Thank you so much, Dr. Poland, for this moving and definitely inspiring presentation. Just to touch on a few things first, unfortunately, this webinar does not offer continuing education hours. However, we will have this recording available within 24 hours after this presentation is over. So that first question that we have for you is, does suicide only affect individuals who are diagnosed with a mental health condition?
Oh, great question. Individuals with mental health conditions, most commonly depression, are often at risk, but many individuals have died by suicide who, up until that point, had no identifiable mental illness, had never received treatment. There's particularly a lot of concern in America about middle-aged men who never sought out any treatment, and all of a sudden, usually with guns they owned, they died by suicide.
Our next question, what is the best way to approach a patient who has expressed experiencing suicidal thoughts in the past when treating them in therapy?
Well, I think first and foremost, we need to be very calm. All the skills that therapists have about rapport building and building that relationship, but I do believe we must be direct, but we need to ask the questions in a way that encourages them to share with us. If I were to say to you, Brittany, something like, now I know you'd never think about suicide, you see how I just stopped any communication. In fact, I've been a therapist for many years. It's relatively common that some of my patients have expressed suicidal thoughts. Have you ever had those thoughts? And if so, let's talk about it. So calm, matter of fact, but in a way that encourages the patients to actually talk with us about what's really going on.
Okay. And our next question is, do most suicides happen without warning?
All right. I didn't quite catch all of that, Taylor, but I think the question was, does a suicide ever occur without warning? I'm sure that it has, but all the literature says those warning signs I showed you present 80 to 90% of the time. But I also use the term subtle. Years ago, a mom said, this is the day after her son died by suicide. And I hope everybody listening will always use the term died by. You tell me my dad committed something, I might say you commit a crime, you commit a burglary. Use the term died by, it seems to imply they traveled a long road. It was everything and everyone. It was everyone's fault, yet it was no one's fault. So the mom says, there was only one thing. The day before he died by suicide, he said, Mom, do you think it's right? Parents are suing musicians, claiming music lyrics caused their kids' suicide. Well, the mom just answered his question. She said, no, I don't think that's right. She wishes, obviously, she'd have just sat down and said, interesting you would ask about that. Let's talk about suicide. You know, it wouldn't be that unusual for you to have that thought. And here's one of my great frustrations, and that is somebody gets hospitalized for being suicidal. Hopefully they get great treatment, okay? Now they're back with their family. And what's like the last thing their partner or their parents like ever gonna bring up? And instead it should be something like, you know, you could have those thoughts again. If you ever have those thoughts again, let's talk about what you should do. So just getting treatment and now out of the hospital, that doesn't mean that some of these thoughts might not continue. That's where the safety plans come into place. That's where we need greatly to increase the communication between private practice personnel, hospital personnel, and schools in particular. Having worked in schools full-time for 26 years, the people that I just mentioned hid all kinds of important information from us. If I actually know the kid was in the hospital because they were suicidal, I can help them at school. I can reduce some of the academic pressure. I can follow up. I can coordinate, but I can't do any of those things if the parents don't want me to know, and the private practitioners and the hospital personnel don't push for sharing information with school counselors and psychologists.
Okay, so the next question that we have here is dealing with teachers. Some are wondering if there's immediate and helpful reply that a teacher can respond to if a student mentions suicidal ideation, as well as what are the boundaries for a teacher to disclose information to a concerning parent.
Okay, well, I believe strongly teachers need to be very alert to suicidal behavior, changes in behavior. Now, really, the teacher is not the person we want responding to suicidal individuals. They need to work as a team. Now, we desperately need more social workers, counselors, and school psychologists, especially here in Florida. But the teacher needs to share their concern with one of those professionals and do it immediately. It isn't unusual for somebody to say, I found the note about the suicidal kid in my box. It's been there for 2 days. That's not good enough. It's like, and then here's an example. The kid was researching how to kill himself online in his high school class. The teacher noticed it and says, go see the counselor now. But the kid walked out the first door. Thankfully, tragedy wasn't the result, but that kid should have been escorted to the counselor. So teachers have a really critical role here in identifying the warning signs and making sure school mental health professionals know. And then the school mental health professionals will be the ones notifying and coordinating with parents and community treatment.
Our next question piggybacks off that a little bit. What do we tell a student or client if they express that they do not want you to contact their family or parents?
Well, this is the easiest to be answered at the K-12 level. I've already answered it. In a school setting, I am contacting their parents. I'm going to explore with them what their concerns are. I'm going to let them know I've been at this a long time. I'm going to use every skill I have to get a supportive reaction from their parents, but their parents are going to be notified if they are a K-12 student. Now, we also talked about the college setting and how much more controversial that is, but let's at least discuss how we might be able to get a good response from parents. And those people in private practice, they're going to have to make their own decisions about involving parents. But I'm always going to recommend, let's try to get the parents involved as much as possible. I'm going to argue very few things change in a kid's life without the support of their parents. So how can we get them more involved and supportive of our treatment?
And this next question also piggybacks. In regards to the parents and the support of the parents, what can one do if the parent isn't taking what you're cautioning them about their child, and also if they're not taking their child's statements very seriously about suicidal ideation?
That's a great question, Melissa. And I know that our time is coming to a close. I don't know, maybe this should be our last question, but here is what I think is really important. When a kid is a minor and their parents are not taking suicidal behavior seriously, I'm going to do my best to help them take it seriously. But if they do not, I had a parent tell me one time, he said, I don't care if you can get me counseling for my kid in the community for $1 a week, I'm not doing it. Sir, you can't possibly mean that. Oh, but I do. You know, he stole that car. He ran from the police. He ran over and killed 2 pedestrians. We're going to be sued in civil court for sure. He should just kill himself. Sir, you can't possibly mean that. You're going to give me no choice but to call the Department of Children and Families. It is negligence not to get help for a suicidal minor. So I'm going to do my best to try to get a positive response, but if I can't, I'm going to make that call. And very commonly, parents said to me, all right, I'll make an appointment for them. But you see, I'm checking with their kid the next day. I'm calling the parents if they didn't make that appointment. And, you know, maybe this is an example that can only happen in Texas, but I think it really illustrates something we have to change. Day before the December holidays, I notified the parents that their child is suicidal. I actually made an appointment for their kid at the mental health center in the community. Now, in reality, I should have really been checking over the holidays, but it seemed like they have the appointment, they're going to follow through. But the first day back in January, kid's name was Tim. So I called Tim in, find out, no, they canceled that appointment. Now I'm just trying to make small talk. And I'm like, because I know I'm going to be calling the parents and telling them, I don't agree. And if you won't follow through, I will call protective services. But as I'm making small talk, I said, well, Tim, how was your Christmas? No, not too good. Well, what'd you get for Christmas? Can anybody guess what his parents got him for Christmas? They got him a gun. Now, they had probably purchased the gun before I notified them of his suicidal behavior, but they should have taken that gun back. So this is a very challenging area, but we need to be very direct. This is what needs to be done. Suicides do happen. They have happened. We've got to do more to prevent suicide all around the world. And we begin with basic education. Suicide is preventable. Suicide is not destiny. It is not inherited. You're not going to cause somebody to be suicidal if you bring it up. If anything, it gives them a chance to unburden themselves and realize, I'm not the first person to feel this way. And everybody needs to know the local, state, national resources wherever they reside. But I want to turn it back to Dr. Perez, but I want to thank everybody for tuning in, and these slides will be sent to you, and good luck with all of your important work for prevention.
Thank you, Dr. Poland. We will actually be sending everyone a link with the video so that you can share with anyone that you want. That'll be sent to you within the next 24 hours. You're going to be receiving an email from psychology@nova.edu. We did lose some of our students that went into class, and I just would like to thank everyone for joining us. Again, you will receive the video from psychology@nova.edu. We do host webinars occasionally from the NSU College of Psychology. These webinars are free and open to the public. Feel free to share. The address where they're located is www.nova.edu/Shark Chats. Melissa and Brittany, thank you so much for joining us. And any final thoughts?
Thank you everyone for coming out from near and far. I know that right now is a difficult time, but it seems like maybe Zoom was able to help us access to people across the nation, and I'm really thankful for that and thankful for all of you for joining. Thank you again, Dr. Poland and Dr. Perez, for helping putting this on, and everybody have a good day.
So one last thought. Life is a struggle right now, but we will get through it. There is a future. And that's a message for everybody affected by the virus. That's a message for any student, client, a patient who's suicidal. We need to be there for suicidal individuals every step of the way to help them. Thank you all for listening.
Thank you, and have a great rest of your week. Thank you.